Okay, welcome. If everybody who's ready to present is ready to present, we have a huge committee meeting, and those of us who've watched our retirement funds dwindle down over the last couple of years have turned to TV, and those of us who watch CNBC, and I know you're in the room, know who Jim Cramer is. And Jim Cramer talks so fast that I can't understand him at times. So I'm hoping that we aren't quite as fast as Jim Cramer, but we are able to get through the wealth of material that we have to present today, so that we can get to the new concepts, which are basically at the bottom. So with that in mind, let's get started. The first is SWOG 1803. I think he's going to be online.
I'm here.
Dr. Chabra. Hi, are you here?
Can you hear me?
We can. There you go.
Okay.
I'll be happy to do your slides.
Great. Thank you so much.
Dr. Chabra.
This is Saurabh Chabra. I'm at Mayo Clinic, Arizona. Thank you so much for giving me this opportunity to give you an update on the SWOG S1803 trial on behalf of the entire SWOG team. And SWOG S1803, or the dramatic trial, is a phase 3 randomized trial investigating single agent lenalidomide versus lenalidomide plus subcutaneous daratumumab as maintenance therapy following autologous transplant. Next slide, please. So briefly, adult newly diagnosed myeloma patients up to 75 years of age who are within 18 months of starting induction and without progression at any time since diagnosis are eligible for this trial. There are 3 registration steps. Step 1 may be before or after autologous transplant, and the trial has 2 randomizations, which are also referred to as Step 2 and Step 3 registrations respectively. Patients undergo first randomization to len single agent or len with dara within 180 days from autologous transplant. Minimal residual disease is assessed using next generation sequencing on the clonoSEQ platform prior to the start of maintenance and then annually. And the randomized treatment is to continue for 2 years, at which time point patients who are MRD negative at less than 10⁻⁶ undergo a second randomization or Step 3 registration, and they either continue maintenance on their assigned arm or they discontinue maintenance. Next keystroke, please. And patients who are MRD positive, they stay on their assigned treatment arm. Next slide, please. The objective of if you can go back a slide. The primary objective of the trial is to compare overall survival between lenalidomide and daratumumab as the experimental arm and lenalidomide as the control arm. The objective of the second randomization is to compare overall survival of MRD negative patients who continue maintenance on each arm versus those who discontinue. Next slide, please. And here's a timeline of the important milestones for the trial. The first patient, as you can see here, was enrolled in August 2019. Previously, a total of 1,100 patients were to be enrolled on the trial. Next slide, please. So in the end of March, that accrual goal was in fact met, and the study was temporarily close to accrual on 29th March. We have a couple of revisions since then. Revision 7, which involves the use of HydraShift 2x4 daratumumab assay to evaluate treatment response more accurately in patients with IgG kappa myeloma who are in very good partial response. So that revision was activated last month, and revision 8, which involves an increase in the study sample size, is in review with the NCI. And we hope that once this revision is approved, we'll be able to reopen the trial. And I'll talk about that in a second. Let's move on to the next slide, please. So the accrual has exceeded the projection. That's on the next slide. I think we met the accrual target more than a year of the projected date. And if you look at the next slide, this is accrual trends on a monthly basis. Moving on to the next slide, please. Here's a list of the top 15 enrolling sites with more than 16 patients enrolled. And we can move on to the next one in the interest of time. So in revision 8, which is in review right now, there are a couple of important updates. One is the MRD determination based on the clonoSEQ report. We have clarified as to what constitutes MRD negative. The protocol wasn't clear previously, and there was some contradiction in the MRD positive and negative statements, as you can see here. So we have clarified this now. You'll see that in a couple of keystrokes. And MRD negativity is defined as less than 1 residual clonal cell per million cells. And so we could have MRD negativity even if residual sequences are detected, as long as we have less than 1 clonal cell in a million nucleated cells. Next slide, please. So the other change will be the sample size in revision 8, and it will be increased to 1,421 step 1 registered patients. So we have 1,214 eligible patients randomized. Next keystroke. Perfect. Another one. And this increase in sample size will be done to account for a smaller than expected number of patients who have been eligible for second randomization. As you know, the objective of second randomization is quite important. Overall survival of patients who stop versus those who continue if they're MRD negative. And so with this revision, we would have sufficient power to detect a difference in overall survival if we have 91 patients in the len-only arm and 152 patients in the DARA plus len arm. Next keystroke. And right now we have 90 patients randomized, second randomized, out of a total of 330 patients reaching 24 months of maintenance. I apologize for the mistake. It's not 165. It should be 330. So 90 patients out of 330 have been second randomized. Next slide, please. A couple of points I want to bring up today. We do need the documentation of drug destruction for the expired investigational product from the sites as soon as possible. And we'll be reaching out to the sites individually. And a couple of points regarding the step 3 or the second randomization. So 24-hour urine protein electrophoresis is very much needed at 24 months before step 3 registration. And in fact, MRD results will only be released after the 24-hour UPEP has been completed. Another issue is the local MRD results cannot be used to randomize patients in step 3. We can only use the clonoSEQ results for the MRD assessment and for randomization if the patient is in fact MRD negative. And lastly, if the patient is randomized to stop maintenance treatment, then we should follow the protocol and stop treatment, please. And that's it for SWOG S1803. Next slide, please. Now I would briefly present the next maintenance therapy trial, which has been endorsed by BMT-CTN, and that is the EMN30 or Majestic 4 trial. And this is a phase 3 randomized 3-arm trial of maintenance teclistamab plus len versus teclistamab alone versus len alone in patients with newly diagnosed myeloma after autologous transplant. And as you're all aware, teclistamab is a humanized IgG4 bispecific antibody that binds to CD3 on T cells and BCMA on the plasma cells, resulting in T cell activation and lysis of BCMA positive cells. Next slide, please. Teclistamab is now approved by the regulatory authorities in the US and European Union based on the phase 1 data. And so the next slide, please. The primary objective of the trial is to compare the efficacy of tec-len with that of len as single agent and to compare the efficacy of TEC as single agent with that of LEN as single agent in maintenance therapy after autologous transplant as assessed by progression-free survival. So the primary hypothesis is that maintenance with TEC-LEN and with TEC will significantly improve the PFS compared to maintenance with LEN in patients with newly diagnosed myeloma after transplant. And so I am not absolutely sure about the status of the study globally, but I understand that there was a safety run-in that was to be conducted before the randomized portion of the study. And I think that has been completed. So patients in the randomized portion of the study, about 1,500 patients will be randomized 1:1:1 to receive either TEC-LEN, LEN as single agent, or TEC as single agent. Randomized will be stratified by the use of anti-CD38 monoclonal antibody, response to the treatment, and use of consolidation. Next slide, please. And here's a list of the main inclusion criteria. Important to note, patients should not have progressed at any time since diagnosis. Enrollment should be within 6 months from transplant, and they should not have received any maintenance therapy after transplant. Next slide, please. Patients should not have received prior BCMA therapy or immune effector cell therapy or gene therapy. Next slide. MRD will be done centrally by next generation flow and next generation sequencing before starting treatment on the trial at 6 months and 24 months from the start of trial and at the time of complete response. Next slide, please. And here's a high-level timeline of the trial. So we sincerely hope that we have the approval from NCI for the revision 8 of the SWOG S1803, and we can complete enrollment over the next 9 months or so before this trial is up and running and we have more competition for patients. And that's all I had. There's a final acknowledgement slide, and thank you so much for your time.
Any quick questions? Okay, thank you. So we have a proposed timeline for getting 1803 back in working order, Rich, approximately? As soon as the amendment comes in. We talked about this yesterday at the working group, and I think a plan has been set. So hopefully within the next 4 to 6 weeks. Okay, wow. All right. So get ready to look at this. Okay, next is Brian Hess. Is going to talk about SWOG 2114, which is now up and started. And I saw on the website that already 90 sites have opened or plan to open this trial. Here you go.
Thanks for looking at it. Thank you, Dr. Stiff. Let's do that. This one. Okay. Okay, thank you. Yeah, as Dr. Stiff said, we recently activated this trial, and good to hear that so many sites are trying to open this up. We've had a lot of collaboration from not only SWOG sites, but ECOG and Alliance and BMT-CTN. So looking forward to getting a lot of these sites opened. So just a quick reiteration on the background. Large cell lymphoma, the most common lymphoma that we see in our clinics, close to 27,000 patients per year are diagnosed. The majority of these patients are cured, but close to a third of patients are refractory or relapse after frontline treatment. After the second line approval for CD19 CAR-T in large cell lymphoma, CD19 CAR-T is now the standard for nearly all patients with relapsed DLBCL. As you guys heard this morning in the kickoff, this number right here is really why we developed this study. 60 to 65% of large cell lymphoma patients that receive CD19 CAR-T eventually relapse. So although this is a huge breakthrough for large cell lymphoma, we definitely have room to improve. So the question we asked is, how can we identify a patient population that's high risk for relapse after CD19 CAR-T? And we think we can identify these patients with this day 30 PET that they get after CAR T. About 50% of these patients will have a complete remission. About 20% will have progressive disease at or before that day 30 PET, and about a third of these patients will have stable disease or partial remission. Not surprisingly, if you have a complete remission at day 30, you're more likely to have a durable response. About 2/3 of this group remain in durable remission. And if you have a stable disease or partial remission at day 30, the majority of these patients end up relapsing. So only about 30% of these patients will have a durable response. So this is the patient population that we identified as high risk for relapse post-CAR T. And then we had to decide what type of therapies we would give to these patients for consolidation that would not only be effective, but also be safe. A lot of the therapies that were previously given post-CAR T relapse, like cytotoxic chemotherapy, hadn't really proved to be very effective post-CAR T relapse. So we looked at more novel therapies like mosunetuzumab, which is a CD20-directed bispecific T-cell engager. A lot of promising data in relapse large cell lymphoma in the phase 2 setting. Also has the potential to augment circulating CAR T cells in respect to this trial population. Polatuzumab vedotin is an antibody drug conjugate to CD79B on B cells, approved in multiple different lines of therapy in conjunction with other agents, both in relapsed in the frontline setting recently. And then this combination of Moz and Pola together has also shown a lot of promise in relapsed aggressive large cell lymphoma in a heavily pretreated population, where you can see complete remission rate of close to 50% with patients that had received prior CAR T and relapsed, showing similar response rates. So our hypothesis with this study was that giving these patients with stable disease or partial remission, mosunetuzumab alone, polatuzumab alone, or the combination as consolidation would help to reduce the risk of relapse in this group. So there'll be 2 registrations for this study. The first registration is prior to CAR T cell therapy. Patients can be enrolled anytime after they have local consent for CAR T collection up until lymphodepleting chemotherapy and CAR T start. And all patients enrolled in step 1 registration will have this day 30 PET, which will be centrally reviewed. A key inclusion to highlight is, again, these patients need to be candidates for CD19 CAR T, commercial CD19 CAR T, whether it be Lysocell, Axicell, or Tisacell. Can be in the 2nd-line setting or 3rd-line setting or beyond. Diagnosis is diffuse large B-cell lymphoma, follicular lymphoma grade 3B, primary mediastinal. You can have transformed DLBCL, but it has to be from marginal zone lymphoma or follicular lymphoma. Patients can have bridging therapy after CAR T cell collection, but it cannot include polatuzumab or mosun. And if you have bridging therapy with systemic chemotherapy or radiation, you have to have that PET scan repeated prior to LD. Previous POLA is allowed, which is important. We just recently saw POLA being approved with RCHP in the frontline setting. So these patients are allowed to enroll on trial as long as they haven't progressed within 6 months of last dose. Key exclusion are non-commercial CAR T products. This includes CAR T products that are out of spec. This is happening in some constructs more than others. So if you have a product that's out of spec and need to receive it on a single patient IND or expanded access protocol, you wouldn't be allowed to enroll on 2114. So for step 2 randomization, if your day 30 PET is consistent with complete remission, you're not eligible for randomization, and you'll be observed and have disease assessments and biomarker draws per protocol, and you won't have any extra visits on the study. Progressive disease, patients will come off study, be followed for overall survival, and be able to receive therapy as standard of care or in a different clinical trial. And again, these stable disease PR patients are eligible for randomization to one of these 4 arms. There'll be 30 patients per arm. Key inclusion to highlight, patients need to have neutrophil count of 1,000 or greater, platelet counts of 75,000 or greater. We do allow randomization up to 60 days after CAR T infusion. This is important because CAR T cell therapy and lymphodepleting can cause some toxicity, including cytopenias. You can have that at day 30, which would potentially exclude you from the trial. These often get better in the coming weeks, so that's why we're allowing randomization up until day 60. Patients are going to be stratified by stable disease or PR at that day 30 PET, and receipt of CAR T is second or third line. If patients are randomized to observation, they do have the option to cross over to the combination of Mosun and Pola, but they have to have definitive progression compared to that day 30 scan. Primary objective is comparing the 1-year progression-free survival of each one of these arms, Mosun, Pola, and Mosun and Pola combination, each versus observation, trying to improve that 1-year PFS from an estimate of 25% in the observation arm to 50% or greater in each of the consolidation arms. So for each of the treatment arms, gives or offers time-limited therapy for these patients. For arm 1, you see Mosun is given a step up for cycle 1, and then is given on day 1 of each subsequent cycle, step up to help mitigate cytokine release. Arm 2, Pola is given on day 1 for a total of 6 cycles, and then arm 3, Mosun is given the exact same way that it's given in arm 1, and Pola is started in cycle 2, day 1, but again, given just for 6 infusions. So one other important part of this study that we've been working hard on is potentially refining who is high risk for relapse after CD19 CAR T. We know that we can help predict who is going to relapse post-CAR T with minimal residual disease, but we don't have a lot of refined data in terms of these definitive subgroups, such as patients with stable disease or partial remission at day 30, patients with CR at day 30, as I said. Close to a third of these patients are relapsing after they obtain that CR, and we don't have good clinical predictors which patients are going to relapse and which patients are going to have a durable remission. So for all of these patients registered to step 1, they will have biomarker draws throughout the study, with the first time point being prior to lymphodepleting chemotherapy and CAR T. All patients will have that second time point at that day 30 scan. And then after that day 30 scan, it'll be based on have the PROs in the protocol. These are nearing completion, and we anticipate that they'll be included in the protocol in first revision. Geeta and Ajay Major have worked really hard on this and done an excellent job. These are also going to start prior to CAR T cell. So again, we assume that close to a third of patients will have stable disease or partial remission at day 30 PET. We're assuming a 10% dropout rate from step 1 to step 2 randomization, which will bring us to estimate of 396 patients to enroll into step 1 in order to randomize 120 patients. So again, we've been promoting this not only through SWOG, but through all the CTEP sites, and I've had a lot of great cooperation. So need close to 400 CAR T patients. So I'm really excited to finally get this activated and kicked off. We estimate close to 24-month accrual if we meet all these time points. And then I just wanted to include a slide about how we would potentially talk to patients in clinic. As I said, all these patients are getting standard of care CD19 CAR T for large cell lymphoma. So I think this is a study that's going to be, relatively easy to enroll patients on 4 sites. I think it's going to be, I think it's going to be attractive for patients to hear about this. So again, all patients enrolled on 2114 get standard of care CAR T at that day 30 PET, which is centrally reviewed if you have complete remission. Again, you have some additional blood draws, but other than that, those imaging assessments really mirror the standard of care, so you have no extra visits for those patients. Same for progressive disease. Those patients are coming off study followed for overall survival, but are not going to have any extra visits. And then for the patients with stable disease or partial remission, as I said, the majority of these patients are likely to relapse. So I think a lot of patients are going to see this as an advantage to have the potential to be randomized to one of these arms of consolidation, and they have 3/4 of a chance to be randomized to one of these therapy arms. And even if they're randomized to observation, they have the option to cross over to Mosin and Pola if they do progress within a year. So again, really excited to get this activated. We actually registered our first patient to step 1 registration this week, and need a few hundred more. So please open this up at your sites. But I think it's going to be, a good sell to these patients. But happy to take any questions if I have time.
Brian did yeoman's work in getting this through the system, and appreciate everybody's help, including Jonathan's and Rich's in helping get the initial design set. And we're going to hear about an exciting new possibility for those that have progression of disease a little bit later, so that incorporated into this might be another attractive possibility for somebody to consider enrolling. As I said on the website today, CTSU, there are 90 sites identified as being potentially interested in opening this. So we hope that that will happen. The one question that I've gotten is, I'm a community center, I don't do CAR T cells. How does that work?
Yeah, so currently what we have in the protocol that if you're a community center, you can only enroll on the study for the CAR T if you're the site giving CAR T cell therapy. And so we've had some questions about, can those patients go back and potentially get consolidation at those community centers? But those community centers would then be responsible for all the data submission and data recovery for all of those patients. Currently in my practice, even if a patient from South Carolina is coming to see me and they're coming from 2 hours away, I'm still following them up frequently post-CAR T. So as it stands now, we're looking at this with our statisticians, but as it stands now, if you enroll in study and you get consolidation, you'll be getting that at the site that enrolls you at the CAR T site.
What about if they're randomized to observation? They still have to get the scans done, but can they be followed by their local team?
They can be followed by their local team as long as those, but the sites that are responsible for the data collection and submission are still the sites that enrolled that patient. So if they can get those scans, that's fine. And honestly, with those scans, again, even if those patients are coming from 2.5 hours away, I'm getting those scans at MUSC. I think most of the CAR T physicians are doing that as well. They become, you saw it on CR, it goes to 100 days after CAR T, then 180, then day 365. So those patients are coming to see me anyway.
Any questions, comments? Is there anybody not going to participate? Just raise your hand if you're not. Otherwise, we'll assume that everybody is. Great. Thank you. Thank you,
Thanks.
Brian. Again, Brian and Nash Hussein are available 24/7 for any questions or issues. Brian, perfect timing. He really did a good job. We're going to hear about the mantle cell ECOG trial. Brian, you ready to go?
Glad that worked out. So so this is the frontline sort of consolidation study for mantle cell lymphoma, deciding whether you need a transplant or not, to see if you can sort of be spared from getting a transplant if you have an MRD negative CR. So this study, you can get any induction therapy, then you have your MRD tested by adaptive biotech and get restaged. If you're in a complete metabolic molecular remission, then you get randomized to either an auto transplant or no auto transplant, and everybody gets 3 years of rituximab maintenance. So and then if you're in a PR, or if the patient's in a PR or MRD positive, or they have an MRD indeterminate status, then they just stay on the study and they get 3 years of rituximab maintenance. They get an auto and a 3 years of maintenance as standard of care. So we hit a little bit of a snag here, where at ASH there was the triangle study that was just presented in abstract form, at least. This is just to remind you, there's 3 arms that was done by the European group. There was an intensive induction regimen, R-CHOP alternating with R-DHAP, followed by an auto transplant, followed by observation. That's the control arm, the sort of standard of care. Initially, the rituximab maintenance was not included because this study goes back quite a few years before the French study that showed the survival benefit for rituximab maintenance. Kind of halfway through the study, they added the rituximab maintenance on. So about almost half of the patients didn't get rituximab maintenance. So then the second arm is to add ibrutinib to that. So they added ibrutinib to the induction as well as 2 years of maintenance ibrutinib afterwards. And then the third arm, they did the same thing, but took out the auto transplant to see if you could spare patients from the auto. So this study showed a benefit of the ibrutinib over the auto transplant. If you compare the auto plus ibrutinib versus the auto alone, looking at the auto transplant versus the non-transplant ibrutinib arm, the auto transplant failed to show superiority and actually probably looked worse. The 2 ibrutinib arms looked pretty similar. However, the follow-up was fairly short with this. And if you kind of take that first top picture there of PFS and imprint it in your mind and look at this study, this is the French study that showed the benefit of rituximab maintenance. The curves look almost identical actually between the winning arms and the losing arm. So basically the observation arm without rituximab maintenance looks very similar to the control arm in the triangle study, where about half the patients got rituximab maintenance. So one could argue potentially that the ibrutinib was basically just making up for the lack of rituximab maintenance in a lot of those patients. So do the preliminary results from this triangle study change practice? I think the answer is a little unclear. This is a courtesy of Tim Fensky gave this slide, so I'm going to kind of go through his talking points here. But I think one of the points is that the follow-up is fairly short, so it's median of 31 months. So the patients were either still on or not very much out after the ibrutinib maintenance therapy. So the curves could change as that gets out farther. Perhaps the curves could cross. So we need longer follow-up. We know that the auto transplant alone, we now have pretty long data from the Nordic study and the European MCL Younger study, where the median progression-free survival is 8 to 10 years, just with the standard intensive regimen and auto transplant. So that's pretty good. And whether the ibrutinib arm will beat that, I think is unclear as you get out that far. We talked about the control arm already. Furthermore, even if you wanted to follow the triangle pattern, the triangle approach, ibrutinib is being withdrawn from the market voluntarily by pharmacyclics. So one could argue we could just substitute acalabrutinib or zanubrutinib. It's unclear whether whether the insurance problems getting those covered, and also with how to incorporate those in regimens that we're more commonly using in the US than the R-CHOP and R-DHAP regimen. And then also, even for people who have bought completely into triangle, the EA 4151 is a difference. It's asking a different question about the benefit of a consolidative auto transplant in MRD negative patients. So I think it doesn't necessarily kill the study. So there are still a lot of centers, I think, there may be a few that have kind of backed away and considered auto transplant dead in mantle cell lymphoma, but there are still a lot of centers that are still offering this to patients. So here we are. Where we stand with the study is that as of the beginning of about a month ago, we had, so the original randomized goal was to get 217 patients in the A and B arms, which is the two randomized arms. We've actually surpassed that now. And the reason we've kind of kept going is that we hit a little bit of a snag, which was that there were 10 to 15, part of a small problem was there was 10 to 15 COVID deaths in each arm, sort of on the early side. But then more importantly, a number of patients were, particularly in the transplant arm, were refusing their assigned therapy. Basically they got assigned to a transplant, were secretly hoping not to get the transplant and then backed out. There were actually a few of the reverse where they wanted the transplant, didn't get assigned to it, but only about 4% of those compared to 16% of the other arm. So that's kind of thrown off the statistical power of the study. We had talked about, before the triangle data came out, we talked about maybe adding, a couple hundred patients, which is actually what it takes. Even though we're only, 16%, you have to actually kind of like double that statistically to get to the full power. We thought maybe that wasn't going to be feasible after seeing the triangle data and worrying that people were going to back off on accrual. But it turns out now that one of the things that nice things about the study is that when we first projected the total patients needed, that was based on an estimate of the MRD negativity that we kind of underestimated. So we ended up exceeding that and randomizing more patients, a higher percentage of patients than we initially thought we would. So we're kind of ahead of the game on that. And basically the total, this 689 patients here is the total that we projected we would need. If we just stick to that total, we should end up with quite a few more, extra randomized patients that, as we'll talk about in a bit, should hopefully make up for that most of that difference of the power problem. So this is where so accrual back in before the pandemic was about 16 patients per month. That's kind of dropped down a bit, as you imagine, during the pandemic. When it got to after the triangle presentation, it's kind of dropped a bit more. So we're getting at about 6 to 8 patients per month. And at that rate, it'll take another 1 or 2 years to hit the 689 goal of 689 patients. If we do make that goal at the current rate of randomizing patients, we'll end up with 544 randomized, which is actually a little over 100 more than we initially had planned. And with that extra number of patients, looking through the statistical power, it looks like that'll actually probably pretty much preserve the original power to calculate a 6-year difference in 6-year overall survival as the primary endpoint. So, but it's going to take a while because these patients do very well. So to get enough survival events to actually do the analysis is going to take some time. So one option would be to close the study now and say, let's just try to get a faster readout. I think most of us on the study would prefer to hang on until we get to full 689, try to preserve the power, try to make it so that the study is more interpretable later. And that, that would take 12 to 18 months at the current rate. Preferably, we would like to try to push that number up, see if we could make one big push here and get the accrual up a little bit, back up to about 12 per month, in which case we could wrap it up in about a year. So this is where we are as of early May, 578 out of the 689 patients. So just a little over 100 to go. SWOG is kind of in third place here behind ECOG and Alliance, but there are some very active sites in SWOG, particularly City of Hope and Kansas University, Utah, and Seattle have all done very well. So thanks everybody for supporting the study, and we'll see if we can try to get to the finish line here, and I'm happy to take any questions.
So they sent out a survey for centers. What did that show?
I didn't get the results.
The results.
Yeah, Tim sent that out. Yeah.
So we are querying the centers to see if people are going to close the study now or continue it, and I'd be happy to hear any comments from the audience regarding whether or not they're planning on closing it or keeping it open and trying to finish up. Obviously, if there's a borderline improvement, but not statistically significant, and we close it, we might miss an opportunity to really help define the optimal therapy for MRD negative patients.
I don't understand why the triangle study is even relevant to this. This is a different population of MRD negative patients. Triangle study, in my opinion, is fatally flawed because they did not redesign their statistics when they came in late at the rituximab maintenance. And so the results are, in my mind, completely uninterpretable for that population, let alone being in any way applicable to this population. So I would say that people should remain very enthusiastic about this, because this is an excellently designed study, and is focused on a specific good risk population by virtue of MRD detection after the induction, and will answer an important question that everybody wants to know the answer.
And this is how we do ALL studies, and it's how we're going to do AML studies and high risk MDS after allotransplant. We're to know what we're treating rather than just guess. And that may be why the FLT3 trial was negative, because we didn't know. We hopefully will know retrospectively, but we don't know that now.
I think the only thing I was thinking about you referring to this was even as patients, set the patients based on that data. But I think we've seen a little bit of pinpoint referral, but we're still actively trying to put patients on what we've seen. So I guess that would be my own concern. Are they going to be sent to being considered for transplant?
Tell them to call me.
Be careful.
We have your email address.
You three are still open, but you rank number one on the action. Plenary session, the highest ranked abstract, the community that heard them, right, from this community about differently, well, worldwide compared to the action. There's no question for me to pick that number one. Should say it's in something, what, you say, try to change
I know.
community view. And also, not necessarily transplant supporters. Usually look for reasons not to transplant. So just to say there is, you can point out to one side, there's also a perception.
Okay, so again, I think people will vote with their feet, and if the accruals dwindle down to 1 or 2 a month, they'll probably end up closing it. And if they continue at 6 to 8 per month, I think we'll continue it. So maybe sending a letter out to community sites in general, or maybe an editorial. If it hits the JCO, an editorial might be the way to go. I think we got a little connection there. That would probably fix that. Okay, thank you.
Thanks.
Next is Dr. Hagan, who's going to talk to us about the trial 2113 for amyloid and the status of this trial as it's getting ready to be opened.
Jeez, a little unsteady up here. Okay. All right. Thanks, Pat. So this is it's a trial that we've been working on for really a couple years, more really intensely in the last year. I mean, we're getting a little close to the finish line. This too has been an intergroup effort with ECOG Alliance, the BMT CTN, and many members throughout the SWOG group. So in sake of time, I'm going to skip the background, but essentially, there's been some treatment paradigm shifts in amyloid. DARZALEX has really impacted the treatment of the disease. The Andromeda study has now led to actually the first FDA approval for therapy in amyloidosis, which is DARA-CyBorD or DARA-VCD. So, we feel like this is a really ripe time to really ask the question in a formal way of truly what is the role of high-dose chemotherapy and transplant in this disease. So for those of you who don't do a lot of amyloid, the primary objective of this study is modified progression-free survival. This is a composite endpoint, really looking at the important, all the important endpoints in amyloid patients. So this includes survival, hematological progression, but also importantly, organ progression, cardiac and renal. So we know we have a lot of amyloid patients who get into good hematological responses, but have organ progression, and that is an important endpoint and impacts their care. There's a lot of important secondary endpoints we're looking at on this study: quality of life, survival, individual organ responses, and then importantly, MRD in both the blood and the bone marrow, and I'll come back to that in a little bit, and treatment-related mortality. So there's actually a fair amount of treatment-related mortality, even in non-transplant approaches in this disease, so we'll be looking at that between the two arms. So this is the treatment schema. Again, this is a randomized phase 3 study. All patients based on eligibility that I'll come to in a second will undergo registration step 1, following which they'll go through 3 cycles of standard DARA-VCD induction listed here. Following that, if still eligible, they'll be randomized 1-to-1 to either continue 3 additional cycles or proceed with high-dose chemotherapy and transplant. We're not mandating stem cell collection, but we're highly recommending it on the trial. And the protocol allows for time to do that. Following their consolidation therapy, regardless of which arm they're randomized to, they'll go on to complete 18 months of daratumumab maintenance, and they'll be followed subsequently after that. Key eligibility at step 1 registration, essentially these are transplant eligibility criteria. So they have to be eligible for high-dose chemotherapy, less than 70, have biopsy-proven disease. They have to have trackable disease in the blood, urine, or the bone marrow. And importantly, at least a difference in their light chains greater than 2, because there's no validated response criteria with lower disease burden than that. The rest of these are standard cardiac criteria, blood pressure, and then kind of organ criteria. They have to have a creatinine clearance greater than 30, and that's based on data that transplant actually leads to a lot of end-stage renal disease, and creatinine clearance is lower than that. And they are allowed previous therapy up to 1 full cycle of at the discretion of the enrolling provider. So it doesn't have to be SWOG, but it can be essentially anything for up to 4 weeks of treatment. Then after they undergo their 3 cycles of induction, there's some additional eligibility criteria at the time of randomization. This is primarily achieving at least a partial response to their induction. So if they're not responding to SWOG, you probably shouldn't give them more of the same therapy. And then they have to be able to collect, obviously, enough stem cells to proceed with transplant for those who are randomized to that arm. So our methodology here, so this is the experimental arm is the high-dose chemotherapy with transplant. That's compared to DARA-BCD in a 1-to-1 randomization. We're assuming based on published data that the MOD PFS for the DARA-BCD arm will be about 31 months. So we're looking at a total of 143 participants per arm that would need to go through registration step 2 in randomization. This would correspond to about an improvement of about 18 months in the MOD PFS for the transplant arm statistically. So the final analysis will be done no later than 4 years after the last patient was enrolled or after 192 events. So we're anticipating about a 15% dropout. There's going to be a very small amount that will drop out due to less than partial response to their induction. The response rates, thankfully, with that DARA-BCD are really high. We're definitely going to lose some patients not being eligible after those 3 cycles. That's definitely part of the disease course. So we've estimated that to be about 15%. So that puts us at 159 per arm that we would need to register at step 1 in order, again, to have enough patients eligible for randomization at step 2. We talked about a lot of stratification factors. I think this was one of the challenges. But statistically, we could incorporate 3. We're looking at the European modification of the Mayo 2004 stage, which really captures your cardiac involvement. And then hematological response, because those patients who get into a VGPR or better with their induction definitely do better long-term. And then 1114 translocation, because there's some difference in response for transplant versus no in those patients. I think importantly on this study, there's a lot of translational work that'll go on because it's very possible these 2 arms could have similar approaches and the primary outcome could be negative. So we're really hoping to gather a lot of information regardless. We know that achieving deep responses in amyloid, just like in myeloma, leads to prolonged survival and progression-free survival. There is a lot of data on next generation flow in amyloid, but really not much on clonoSEQ. Remember, amyloid has a much smaller disease burden in the bone marrow than myeloma, so getting that initial clone and tracking it over time is much more problematic. So in the study, we'll be looking at next-gen flow for the MRD. And really, we don't know how deep of a response you need to prevent organ progression. So there's really minimal data on this. So this is a unique opportunity to look at that. Further, we'll be doing every 3 months peripheral blood mass spec assays. Those samples will be collected with a later analysis at the end of the trial. So that's going to give us a unique opportunity to compare bone marrow next-gen flow with peripheral blood mass spec and see if they correlate, which could definitely impact patient care in the long term. So the primary endpoint in terms of our translation will be MRD negativity in the bone marrow post-consolidation. So again, that's the randomization question here. I'm not going to go through all the secondary and exploratory endpoints, but basically we're looking at comparing the 2 methodologies over time at various time points on the study, post-induction, post-consolidation, and then 1 year post-consolidation. Finally, there's built into the study is a PRO plan. We're looking at the Promise 29 tool. This has been validated in amyloidosis with the help of Anita D'Souza. We put this into the study. This again will be, we think, quite important if the primary endpoint is not met to figure out what's the quality of life of these patients, what's their experience when they're going through therapy. We're going to see more, neuropathy with Velcade. We'll see more short-term toxicity with transplant. So in the end, I think this will be an important thing we can talk to our patients about when they're considering this therapy in the future. And there's some additional exploratory endpoints, again, that we'll be looking at. So this is where we are. So the study's on a pretty tight timeline at this point. It's been formally endorsed by the BMT-CTN. It's been approved by the NCI Steering Committee, and the FDA formally approved it in March. We've resubmitted a round of CTEP inquiries recently, so we're anxiously anticipating those responses, and we'll hope they'll approve so we can move forward to formally opening the study. So I think that's the last slide. Yeah. So that's all I had. We're really looking to keep engagement in transplant centers. We know a lot of these patients do come in from pretty far away in certain parts of the country. So, we'll be really doing a lot of work within SWOG to, again, kind of formally promote the study and make sure awareness. But I know clinically for us, this is a question we're facing frequently when these patients get in referred, when they're in a good response. And, we really don't know the answer. There was one study that looked at this, it's 20 years old, it's an outdated study. So we think this is a really unique opportunity through the cooperative group mechanism to answer this question. So with that, I think I have done.
We did see a lot of enrollment on the isatuximab study for relapse disease. So we know these patients are out there. We know that SWOG centers have these patients. So we're hoping that people will enroll, obviously at the time of diagnosis. So any questions or comments? Maybe if I ask again, is anybody not going to open this trial in the room? Good.
You can't raise your hand on the table. So.
Okay, thank you. So we're imminently ready to go. I think if we can do what we did for the consolidation CAR T study, have like a seminar for investigators, especially for the MOD PFS endpoint, because that's pretty new to everybody, and how that's going to be determined, and what studies need to be done and when and how. I think is going to be critical to making sure that the trial is successful. Next is Brian Hess again. This is the chemotherapy versus immunotherapy salvage for autologous stem cell transplant for Hodgkin's lymphoma. And this also has been impacted, I think, by the recent SWOG study, SWOG-led study for upfront therapy. And he's going to talk a little bit about that as well. So, Brian.
Thanks. So Vishali Kenkri is the study chair for this ECOG-led study, and she made these slides and let me use them. And I think they're keep the point across. So this is a randomized phase 3 trial of looking at chemotherapy alone versus pembro chemo as salvage therapy for relapsed classical Hodgkin lymphoma patients who are candidates for autologous stem cell transplant. And a lot of us know that there is really good phase 2 data looking at adding checkpoint inhibitor therapy with these various salvage regimens, whether it be pembro GVD or Nivo ICE, pembro ICE, but these have not been proven to be better in the phase 3 setting. So this trial is looking at, again, patients with relapsed classical Hodgkin lymphoma who are auto stem cell transplants, which are the majority, the greater majority of patients, Hodgkin patients that do have relapse, and randomizing them to chemotherapy alone versus pembrolizumab and chemo. So investigators will have the choice to for a few of these chemotherapy backgrounds. You can see ICE, GVD, and BV Benda. Each investigator can choose that for each patient. The sites don't have to be preordained in terms of what regimen that they're going to use. After you get 2 cycles of chemotherapy or pembro chemo, you get a PET scan. If you have stable disease or progressive disease, that will count as an event, and that patient will come off of trial. If you have complete remission, I think all of us are going to take that patient to stem cell collection and then autologous stem cell transplant. If you have partial remission, the investigator can move that patient on to auto stem cell transplant, but they also can give another regimen of one of these choices. So you'll have 2 other choices that you can use and give that patient another salvage regimen. But if you're on the chemotherapy alone arm, so arm A, and you gave ICE first and you had a PR, you can't cross over and give pembro GVD if they had a PR, and vice versa. So patients that do not have a CR after auto stem cell transplant will also count as an event. We had a lot of discussions on what we defined as a PR. We have that defined in the protocol, and that's on this slide here. So the primary endpoint for the study is 2-year event-free survival, where we're estimating the 2-year EFS of the chemo-only arm, 65%, and trying to improve that by 15% in the pembro chemo arm. again, the events include failure to achieve PR or CR to salvage and failure to achieve CR after auto, including progressive disease and death. So in order to get this study fully accrued, it was estimated that we'll need 334 patients randomized. Currently, it has CRB approval, and the activation is looking to be next month. So Vaishali came up with a number of, let's see. Okay. We don't have, I kind of memorized what the answers were, but we don't have Vaishali came up with these surveys for to try and estimate if there's going to be excitement for this trial in the current era of Hodgkin lymphoma and what we've learned potentially over the last couple months with some frontline therapy results. So the first case is a patient who was on that study, 1826, was randomized to Nivo AVD, relapsed 8 months after completion of therapy. And the question was, would investigators want to still enroll on this trial? And there was 21 centers. These were only sent to SWOG centers. And I believe 17 patients or 17 centers said they would select A, so they would enroll patients without hesitation. And in case 2 is very similar, where grade 3B patient got ABVD and recurred 6 months after initial treatment. And in this scenario, they asked the same question, would you enroll on this trial? And again, it was about 80% would enroll without hesitation. There's about, I think there was 21 centers that answered. And then in case 3, we see a patient with 2B bulky disease, again, got ABVD, was randomized to that chemotherapy alone arm, had a partial remission after 2 cycles of GVD, and it's asked, would you keep this patient on study and switch to ICE or BV-Benda prior to autologous stem cell transplant, try and get this patient into a CR, or would you take this patient off study and give a checkpoint containing regimen? And a little over 50% chose A. So a little over 50%, I think it was about 60% chose A. They would keep that patient on study, and about 40% that they would take that patient off of study and give a checkpoint containing regimen. And they asked it again for that same patient, again has a PR after that second regimen. And this question asked, would you still keep this patient on trial, proceed with auto transplant, or would you again take the patient off and give a checkpoint containing regimen? And that was reversed, where B was about 60%. So about 60% would take patients off in that instance. So I know Vaishali and the ECOG folks had their meeting last week, I believe. She's kind of compiling the answers to these surveys, and I know we're going to have a call in a week or 2 here to discuss them. But I am, if anybody has any questions about the study or has any really strong thoughts, I'm happy to take this back to Brad and Vaishali.
So I guess for me, one of the biggest questions that hasn't been asked is based on the recently completed SWOG study. I think we're going to anticipate even fewer patients coming for transplant. Is this trial going to be able to be completed, or is this going to be another one like the ibrutinib?
Yeah, I mean, I think there's 8,500 patients per year with Hodgkin lymphoma. I know that Nivo AVD, well, never mind. So, typically it was about 80% of patients with frontline treatment were being cured with stage 3, stage 4, but we also see patients that are not cured with limited stage disease. So I think it's going to be a smaller proportion of patients that are relapsing after frontline therapy, but I still think with how prevalent Hodgkin lymphoma is, I still think those relapse patients are going to come. The question are so many of those patients going to already have Nivo AVD and progress within 6 months, in which case they would not be a candidate for this trial. You're not a candidate if you receive Nivo ABD and you progress within 6 months.
So I guess my recommendation for my question would be to go back to CIBMTR and ask them over the last 18 months, how many patients have been coming to transplant? Because like, obviously Nivo ABD is not considered standard of care yet, but if the numbers are continuing to drop off like they are for non-Hodgkin's lymphoma, I think it begs the question of, can we really get the study done? And if the numbers are shrinking, which I assume we are because we're doing fewer of them, then maybe they need to go back and look at trial design or statistical design.
Where there's less than 334 patients.
Anybody else have any comments?
I think I don't know if you guys can hear me. Can you guys hear me?
Sure. Okay, thanks.
Oh, I guess.
Next, hopefully Matt is on the call. This is the MyeloMatch Tier 3 study led by Alliance. It's reduced intensity allo transplant with venetoclax. Matt, are you there? Please say yes. Okay, well, let me have a crack at this then so we can keep moving. This is a randomized double-blind placebo-controlled phase 2 trial of venetoclax with reduced intensity allo transplant with venetoclax maintenance in adults with AML and first complete remission. We've shown these multiple times. Obviously, venetoclax is active even as a single agent in previously treated AML with CRi rates of approximately 20% and double anti-leukemic activity. It's well tolerated, it's orally bioavailable, and it's been studied in reduced intensity FLU-BU2 by Jacqueline Garcia in Boston. So the goal is to improve MRD clearance and relapse-free survival by increasing the efficacy of the conditioning regimen and as a maintenance. So this is a tier 3 MyeloMatch all comers intergroup trial. It's blinded, placebo controlled, and we'll have 2 cohorts, both traditional match SIB donors, MUD transplants, and alternative donors, including haplo transplants and mismatch MUDs that will allow us to expand enrollment to historically underrepresented racial and ethnic groups. The hypothesis is that when you add venetoclax to reduce intensive conditioning, you'll improve your 100-day event-free survival by 20% compared to placebo. And event-free survival is measured as MRD persistence, MRD relapse clinically, or death. And we're going to be using flow cytometry to measure MRD in this study. So again, there are two groups and 2 arms. The first is conditioning with FLU-BU or FLU-MEL with or without venetoclax, and these are for the matched sibling donor transplants, and they will get either tacrolimus and methotrexate, or they'll be allowed to have post-transplant MMF and tacrolimus. And the second group will be the mismatch MUDs and haplos, who will get melphalan, TBI, fludarabine as the preparative regimen with or without venetoclax. And again, patients will get their transplant, and at day 100, we'll have a bone marrow aspirin biopsy, which will determine whether or not they have MRD persistence, relapse, MRD, clinical relapse, or death. And if not, then they're randomized to venetoclax 400 milligrams a day or placebo for a 12-month period of time. Major objectives, the primary is the conditioning. Major objective is day 100 event-free survival, as we talked about. and the secondary are day 30 event-free survival, again measuring MRD only. Regimen-related toxicity, of course, and the maintenance question of 12 months event-free survival from second randomization. Key eligibility are AML and first remission, except for APLs. They have to be enrolled in the MyeloMatch a trial from the time of diagnosis. They will have MyeloMatch MRD testing prior to registration, entry onto the trial, and all MRD analyses will be done through MyeloMatch. They'll have to have either a fully HLA matched donor for cohort 1, or can have a mismatched MUD or haplo transplant for cohort 2. Cord blood is not permitted in this trial. Age greater than 40 for cohort 1, but we're allowing younger patients for cohort 2. Exclusion, of course, are refractoriness to venetoclax containing regimen or venetoclax alone used for AML induction. Planned DLI is not permitted, and patients with HIV, HBV, HCV are eligible per recent FDA rules. Statistics, again, is such that the primary endpoint will require 64 evaluable patients per arm, total of 128 per cohort. And again, there are 2 cohorts. The study will enroll up to 140 patients per cohort to allow for ineligibility and cancellations. Secondary endpoint is conditioning, event-free survival as measured by MRD or clinical progression. We're hoping to have 70 patients, of which 35 are going to be MRD positive per conditioning arm to detect a 20% difference in MRD conversion using a one-sided alpha of 0.1 and power of 0.8. In other words, 35 MRD positive patients per conditioning arm prior to transplant is one of the goals of the study, to determine if we can eliminate, using a venetoclax containing regimen, more patients by 20% than the placebo arm. Primary endpoint is conditioning event-free survival at day 100. And again, we assume a event-free survival of 60% after RIC allograft. With the admission of venetoclax, we're looking for an 80% 100-day event-free survival. We already talked about this. I don't know why, going backwards. This was presented and endorsed by the CTN in July of last year. We added a post-transplant MMF and tacrolimus based on the recently completed CTN 1703 results, showing no differences in outcome and decrease in graft versus host disease relapse-free survival. It's been approved by the MyeloMatch chairs. It's been submitted to NCI. The first review is completed. It was amended and sent back to the MyeloMatch, and we're waiting for final senior council approval so that we can get going and submit this to the steering committee.
What if there's any reason to think that venetoclax could impact GVHD either for better or for worse? And maybe it would be interesting to add that as a secondary or exploratory endpoint.
Okay, so the question was, are we going to be looking at graft versus host disease rates? I think, again, you know, the numbers get really small when you start doing post-transplant psi. Incidence of acute severe graft versus host disease is in single digits. So I'm sure that will be looked at, and I can pass it along to maybe have it added formally.
The field feels a little cleaner if you adjust it side, because that's where all the fields meet. And I think the other thing I would say is that there's no data saying that venetoclax works with P53 AML and reduced intensity, and I would really consider whether you want to enroll those patients or not.
Okay, so the comment was, are we going to include P53 patients? I'll get back to you on that. And the other was just to have everybody get post-transplant psi. Well, that's a problem that some of us have because of the incidence of borderline cardiac failure in giving people huge doses of cyclophosphamide early post-transplant. Patients who might have had a prior history of hemorrhagic cystitis. So I think we're going to leave that, but we'll go back and talk about the P53. I will tell you, and I don't know if Jacqueline is on the call, but I think there were P53 patients in her study. But we'll clarify that for sure. And that's why it wasn't an exclusion. Anything else? Barry, do you have a comment about that P53? Okay.
I would include that in other work.
And this one, are you gonna stratify? Are you gonna include that in stratification, the randomization?
I think there are several stratification factors. MRD, positivity or negativity, the conditioning, and the ELN risk.
Those adjustments for the site of meetings, was possible.
Yes, there will be.
I'm assuming core lining of super size, just to make sure that all the exclusion that.
Well, I think it's not excluded. Only the APLs are excluded. It depends on other risk factors associated with the core binding, obviously.
Are you gonna allow for side dose reductions? Here.
Yeah, I don't think people would. The goal is to have it be the post-transplant side to mirror the CTN 1703. So I don't think that they're going to do that. Okay, let's move on. I'm hoping that Mark is on the call. He's going to talk about the ECOG CR1 post PTCL auto transplant trial.
I'm on, Pat. I don't know if you can hear me.
I can hear you. Can you see the slides?
Okay, good. All right, perfect. Yes, I can see the slides. All right, so we're cooking with gas. So I presented this at last meeting. This is just a quick update. You can go ahead to the next slide, Pat. So I think you guys all are aware of this. Peripheral T-cell lymphoma is a relatively uncommon disease, and historically we've treated with anthracycline-based induction therapy with various regimens depending upon age and CD30 positivity. Autologous stem cell transplant is performed at multiple centers in CR1 in almost all histologies, except for ALK-positive disease in CR1 based on historical data, but there are a variety of different retrospective series. There are some series not showing a benefit. There are some series showing a benefit. As I think all of you are aware, we have prospective data for the role of autologous transplant in CR1, but we do not have randomized data. Next slide. So this is the hypothesis. There is a combination hypothesis. We brought back an OS outcome and still think that an overall survival outcome is the more important of the two, but also added an interim PFS analysis outcome to enable us to have a bit sooner results to be able to publish. And so the thought would be we would improve 2-year PFS by 15% and 2-year OS by 10% in patients who are transplanted in CR1. You can go to the next. So this is the schema, newly diagnosed PTCL. It includes the histologies that are listed below. Everyone receives induction therapy per protocol. Randomization would occur at the end of treatment PET scan. So these patients, that doesn't mean if they're referred to you earlier that you can't enroll them. It's just you need to wait until they actually have completed their therapy. And if they're in PR, stable disease or disease progression, then you can manage them however you see fit. If they're in CR, they're randomized to other observation versus transplant. There'll be a couple of stratifications, either by ALCL versus others, and then some stratifications based on the induction chemotherapy that they received. The primary objective is, as we had just discussed, and there's some secondary objectives looking at histologic stratifications, as well as impact of MRD. So there will be MRD analyses embedded within the study. There's baseline MRD and then MRD post-transplant among the transplant arms. Next slide. So these are the key inclusion criteria. I think that we went through this in some detail on the last slide. And then anytime they've completed therapy within 3 months, they would be eligible. And so the idea is that you're capturing patients who were induced either locally at your centers or within the community who are referred in for consideration of autologous stem cell transplant. And they have to be in CR. And so I think the stipulation for CR was obviously someone with a PR that had any degree of active disease. We did not want to randomize to an observation arm. The other piece is that all of the prospective series and the majority of the retrospective series have looked at a combination of patients who have received a transplant who are in a mix of PR and CR. And so the question here is realistically, if you've had an adequate response to induction, do you really benefit from transplant? Next slide. The statistical considerations, this is a little bit rough. This is a lot of patients. And so I think this is going to be something where we're going to need to have buy-in from all of the various cooperative groups, not just SWOG, but also ECOG and Alliance. This has certainly gone through the transplant cooperative group as well. Assuming an accrual rate of 7 patients per month, we would be able to get this done in the order of about 30 months. So the PFS, you can see here, those PFS estimates are based upon historical data series, and we would require 182 events in order to get a readout. So if we accrue at around that rate, and we're looking at a 2-year PFS, we're talking about from the time that the trial opens, ostensibly to having results somewhere in the neighborhood of 3.5 to 4 years. There's regrettably, for those of us who treat this disease, there are not a lot of particularly interesting novel therapies, and certainly not much going on from a landmark phase 3 perspective that I think is likely to change the landscape of treatment for this disease anytime in the near future. So I do think this question will continue to be relevant by the time the data would be prepared for presentation. Next slide. This is the OS consideration. And so the overall survival estimate would be greater. Part of the reason that we felt strongly within the various lymphoma committees about having an overall survival endpoint is simply that if you have a disease where the randomization is to some sort of treatment versus not any treatment, if the treatment is even marginally effective, you should see a significant improvement in PFS. And so it really, the question begs itself, are we truly improving the overall survival of these patients? And so this was something that was felt strongly by multiple of the cooperative group leaders when we sent this through committee. Next slide. These are the various sample size considerations. And so this had been the major thoughts and feedback that we had received was, do we really think we can get this done? Which is, I think, at least some of the questions that are likely being asked by the audience right now. These are the various sample sizes that have been projected. So we did all of these analyses. If you went with just a PFS outcome, you could use a much smaller sample size, but I would argue probably have a less relevant result. If you had a 3-year OS, it's again a little bit more than a 2-year PFS, but you'd have to wait quite a bit longer. The timeline is a little bit longer. And this hybrid sample size really came in as being what we felt was probably the optimal design, but the question would be whether we would be able to do it. And so I think certainly if there are centers that would not be willing to open this study, that would be problematic in terms of actually getting the study accomplished. I believe the final slide, Pat, is the next one. Is there one more after this? Yes, so this was the only other study I wanted to bring up, which is that the French are doing a prospective randomized study with a primary PFS outcome in PTCL. They are looking at a sample size of around 200. Again, the primary endpoint of this is PFS. These patients, the study is designed slightly differently. In France, they don't have a similar plan of patients getting induced in the community. So the majority of these patients are treated at academic centers from the beginning, and they end up having an early randomization to either transplant or not if they achieve a CR. And so the trial is designed a bit differently, and so there will be some patients that they know will not achieve a complete remission. And so there's some of the sample size considerations there. So this study is actually underway and getting moving. And so I think this study, and then if you back up 2 slides, the sample size considerations are realistically what we have that's available for discussion in this meeting, and consideration with you guys of really getting an honest assessment of if this would be open and if you believe that that you would accrue patients to the study.
Okay, thoughts. All I can say is wow. I just think back to the SWOG 9704 trial, which was B and T NHLs. You didn't have to have a CR, you just have a PR, and it took forever to get that trial done. 480 patients. Are there people that would not open this? So everybody would open it. I think again, my recommendation would be to go back to the CIB MTR and see if this is a realistic goal in 3 years. And maybe you've done that already and can validate that there are enough patients out there that are getting transplant right now. There are the issues, of course, in randomizing between no therapy and therapy, because there's no maintenance or consolidation for the non-transplant arm. So you're going to have, like we saw for the mantle cell, at least a 15% drop off, I would think. Can we get the microphone? Or yelling at me, please.
So you brought up 9704, which I think is relevant for the 2 of us who were here when that was running. But I mean, overall survival is really the key question here. And I don't understand the need to do the PFS if it's adding 100 patients to the list. I mean, to me, that's the easiest thing to knock off. The key question is overall survival. You're probably going to see a PFS difference, especially in the short term, because you're giving patients additional therapy versus not. If we didn't believe there was going to be a PFS difference, we wouldn't be offering that treatment at all. So I think that, you know, that 480 can get to 380 pretty easily if we're disciplined and we want to answer the right question.
Yeah, I agree with you 100%, Jonathan. I think especially given the fact that there's an alternative study that is looking at PFS as a primary outcome, that data will be available. So I think if we're going to realistically add to the literature, not only would we want to have an OS outcome, but that's also what's, as you astutely mentioned, that's the really important outcome here.
Mark, obviously a lot of people have thought about these numbers, you know, in detail, but I'm wondering whether, you know, whether we stay with PFS in combination with OS or not. I'm not sure where the 2-year PFS of 40% on the patients not getting transplant, and if we stand with that, it may be, is it reasonable to estimate that the progression-free survival is less than 40%, and the same thing for overall survival as well? Is it reasonable to estimate that less than 50% of these patients will be alive if they don't get transplant in CR at 3 years? And that may help your numbers, or I don't know, cause a riot, but
yeah,
maybe reasonable to look into.
So what we did was we looked at a variety of pooled data sets, and that was how we ended up on these estimates of 40 and 50%. I agree with you. If certainly if we were more pessimistic, then it might be helpful. I think the hard part here, Brian, is that we're talking about patients who are going in CR, and so there's not PR patients going into transplant, which is going to potentially inflate those cure fractions by a few percentage points. These are all great points.
I don't think anybody doubts that this is a trial that we really should ultimately do. The question is, can we do it? Has this been endorsed by the CTN?
To the best of my knowledge, yes.
All right, well, again, the thing for me is, do we have enough patients to do this even at 380? And I think that's where I would start, but I agree with Jonathan. 3-year OS, it's gonna take a little bit longer, but it's well worth doing it if you're gonna do it at all.
Sounds good. I'll take that back.
Okay, now we have two new trial concepts, a big one and a little one, if you will. And Jennifer Saltz is here from Oregon to talk about genetically modified universal NK cells for CAR T failed patients. Thank you for coming.
And I will do it in 2 minutes.
No, you don't have to.
Right. Well, good afternoon. Thank you for allowing me to present this proposal today. So the proposal is treatment with non-genetically modified universal donor NK cells after CD19 CAR T failure. This audience needs no introduction to NK cells. They are lymphocytes. They have high ability to kill tumor targets. In particular, they're different than T cells because they don't induce GVHD. They really don't cause a lot of CRS, no ICANS. They are really coming through as a really promising cell therapy product. They don't need antigen recognition. They can directly contact the tumor and through perforin and granzyme B cause cell death. And in addition, we can augment ADCC or antibody-dependent cellular cytotoxicity via engagement of a CD16 Fc receptor. So when you look at it an NK cell, there's so many ways to really augment its killing, but it's a nice display of inhibitory and activating receptors, which are completely dependent on the tumor and its cognate receptor. And the receptor on the tumor is usually based on cancer type and actually maturation state. When you look really closely, I mean, the big one that we always think of with NK cells are KIRs, the inhibitory receptors, which are bound through HLA class 1. But there's a lot of other opportunities for NK cells to be activated. And we're going to be focusing a lot on augmenting the ADCC. So these are just general approaches to modulate NK cells. How can we get them to work better? So you can give them cytokines, you can give IL-2, which allows them to persist in the body for up to a week. They usually only live about 3 to 4 days, depending on how you modify them. You can give them cytokines like IL-12, IL-15, and 18. You can generate through these 3 cytokines a memory-like phenotype where the NK cell actually can persist for months, maybe even years. These are all very promising type of NK cells as well. You can actually give them cytokines to make them more educated. You can block their inhibitory, or you can disinhibit NK cells by blocking KIR or by blocking NKG2A antibodies, or you can facilitate ADCC. And so for the purpose of this talk, we're going to be talking about that, in particular with an anti-CD20 drug, rituximab. You can give the most common way of activating NK cells is through haploidentical transplant, where you're promoting alloreactivity. And then you can also use them as off the shelf. And I'm not going to be talking about this today, but there is a lot of really good activity coming out about CAR NK cells as well. So if you kind of focus on lymphoma therapy, there's several off-the-shelf NK cell products. Many of them are derived from different ways of getting NK cells. You can get them through the peripheral blood, placenta, umbilical cord. Fate has a product in which they're using these iPSC-derived NK cells for relapsed refractory lymphoma in combination with rituximab. Take 007 or Takeda has a CAR NK product from umbilical cord blood, which targets CD19 in lymphoma. Gamida has a product as well where they're expanding an apheresis product with nicotinamide and IL-15 for relapsed refractory lymphoma with rituximab. And then Wugen also has an NK cell product. And this is the memory NK cell that I was talking about. So for today, we're going to be talking about Artiva, which is AB101. And just to give you a sense of what this is. So the Artiva product is actually selected for the KIR-B haplotype, which makes it more activated. It also is selected for a high affinity binding CD16 polymorphism at the F158. And this enhances ADCC. If you look at the schematic below, how these cells are isolated is, so they are from cord blood units. You can CD3 deplete them, that removes the T cells. And then through a proprietary method, these cells are activated, expanded, and then they are cryopreserved into a master cell bank. And then they are activated and expanded a second time to become the cryopreserved product that can be given, thawed at the bedside and given. There's no, these are immediate use cells. So what I mean by that is there's like, no manufacture time. These cord blood NK cells actually expand way better than the peripheral blood NK cells, as shown on the figure on the left for you guys. So how does it look in a patient? So AB-101 is currently running, being given to patients through a phase 1/2 clinical trial for patients with non-Hodgkin's lymphoma, and includes Waldenstrom's. So the eligible patient comes in, receives their LE chemo, and then they undergo rituximab infusion followed by the AB-101 NK cells. This is all given outpatient with the hope that we can augment the CD60. If you look at the NK cells, they have a remarkably activated phenotype. So you can see high levels of CD16, high levels of NKG2D, NKP30, NKP44, NKP46, and DNAM1. And these cells in preclinical models have shown that if you combine the NK cells with leukemia targets or lymphoma cell lines, you can see that these cells release a lot of interferon gamma and CD107A, showing that they're activated and engaged in killing. In a mouse model that was presented last year at SITC, they found that using this Raji cell line, that the combination of AB-101 with rituximab improved overall survival. So we are proposing looking at this study for an adjunct for the clinical trial that Brian was talking about. And so I'm going to go over that for a second. So it is currently, this Artiva AB-101 clinical trial is currently open and enrolling at multiple centers across the country. Again, it's for patients who have relapsed refractory non-Hodgkin's lymphoma, B-cell origin. Exciting things that have happened is in January of 2023, AB-101 was granted fast track designation by the FDA for the treatment of relapsed refractory non-Hodgkin's lymphoma and of B-cell origin, combined with rituximab based on really promising response rates. And then there is a ASCO session that will be reporting out the trial in real time regarding, so far the patients we've enrolled and the toxicity we've seen and the response rates, and that will be presented June 5th. So more to come on that. But what I can say now is just that we feel like these cells are very, very well tolerated, and we're excited about the response seen so far. So we know that there are two knowledge gaps. I mean, one of them is that we don't know, there's no standard of care therapy for patients who fail CAR T. And we need to have better treatments for high risk patients. So I don't need to go through this because you guys just saw this, but what we're thinking of is that this could be kind of an adjunct to the SWOG-2114 study. So in particular, we would be focused on these patients who have progressive disease at that day 30, because right now it's essentially treatment per discretion, right, of the MD. And so essentially at this stage, what we would say is that instead of doing like physician-directed treatment, we could recommend like an NK cell plus rituximab approach for patients who have a history of CD20 positive disease. I mean, these patients have to have proven disease progression. We have to have a tumor biopsy result within 6 months of AB-101. So there's not going to be a need for a repeat biopsy. Actually, specimens that are collected within 6 months before the AB-101 dose is permitted. In addition, participants must have not received any lymphoma-directed therapy, really, after the progression until they go on study. We want them to have adequate bone marrow reserve so that they can tolerate lymphodepletion chemo again, and then have adequate hepatic and kidney function. We would exclude CNS lymphoma, anyone with a cardiac EF of less than 45%, active infection, and would not want any additional monoclonal antibody treatment within 4 weeks or surgery. So, I mean, I think that we're excited about this opportunity because I think overall what we're seeing is that We have low risk of CRS, really no ICANS reported. We feel like this is a really well tolerated therapy, and most of our patients are staying outpatient, which is really important after we ask so much of our CAR T patients to go back into the hospital for, various reasons, including CRS. We think it's going to be a quick enrollment turnaround because there's no manufacturing time, and this is an off the shelf, like ready to infuse product. So I think with that, we think also, we would be open to the lymphodepletion either with bendamustine or flu-cy. And I think, yeah, we're hoping to share the response rates in the near future. I think that's my last slide.
You said no monoclonal antibody. What if somebody got TOSI?
I think that's a really good question. I think that there would probably be at least a 2-week washout, but
It's not just for.
Microphone, sorry.
This isn't just for patients who have progressive disease at day 30, though, right? Is it just for the patients on?
Well, I think it would
2114?
depend on how quickly we could get it up and open. And I guess my feeling would be if it's going to take a while to get this open, that it could be anybody who's on the trial or not on the trial.
Okay,
Obviously,
yeah.
the advantage of doing it patients on the trials, we're going to have the PCR data or the molecular disease analysis. So this would be a nice add-on to that.
I just, in my experience, the patients that are progressing before day 30 or at day 30 tend to be tough clinical trial candidates. So, I mean, happy to include them, but probably would include a wider net than that, but happy to hear what other
But
folks
definitely
say.
through a wire net. But some of these people, because we're watching them so closely, that a 25%
Nice, yeah.
increase in disease, they may still not have a lot of symptoms at that point. And we are treating, as time goes by, a less heavily pretreated patient population. So you may not have a lot of extensive disease in these patients that are coming to the CARs, and progression is progression. So it may actually still be a good population to study. Other questions or comments?
Clarify, 6 doses. How many doses?
What in case?
You know,
So how we're doing it, we do them in months and cycles. Usually you get them weekly, and then if you are responding, we actually allow for additional cycles after that.
Okay, so 6 cycles weekly and plus or minus more. Are people interested in this? Should do it for leukemia.
there might be some win for enrollment on some trials. So all patients that progress, we have this to potentially offering too, so. This is not a lot of good things you can offer those patients.
Okay, sake of time, let's just finish up with a few slides on anti-CD47 maintenance therapy after allotransplant for high-risk MDS and AML. We have discussions with MyeloMatch with a variety of potential sponsors, and there was interest on a recent call of doing a post-transplant maintenance trial with CD47 therapy. So CD47 and signal regulatory protein A interact and prevent macrophages from eating tumor cells, if you will. So macrophage distinguished between self and non-self by binding to the SIRP on macrophages to the CD47 on tumor cells, including AML cells, saying don't eat me. If you block the interaction, that blocks the don't eat me signal, leading to phagocytosis of the tumor cells. And the tumor cells are usually surrounded by these macrophages whose number correlates with prognosis. So more macrophages, more inferior prognosis. There are a whole host of these CD47 SIRP inhibitory molecules, including anti-CD47, anti-SIRPA, FC fusion proteins, and FC receptor engagement that all prevents the macrophages from or encourages the macrophages to then do the tumor cells. What's important to note is that in early stage pre-leukemia or early MDS, there's not many of these CD47s on the tumor cells, but as the disease becomes more and more advanced, the incidence of cells with a high CD47 increases, leading again to inhibitory effect of the macrophages in eliminating the AML cells. Here's a sampling of the trials. Everybody's familiar with magrolimab, which is the first molecule tested. It does have some activity and it's already in phase 3 testing. What we're talking about is a trillium molecules, which are now owned by Pfizer. So this interaction increases macrophage phagocytosis of tumor cells, increases NK cytotoxicity, increases DC activity, which can prime T cell cytotoxicity, and anti-CD47 treated macrophages prime cytotoxic CD8 positive cells, which are important to consider in the post-transplant setting. And there is inhibitory effects on Tregs as well with this therapy, all which could potentially in an allograft setting cause graft versus host disease when used. So the most studied anti-CD47 is magrolimab. It's in advanced testing. Single agent activity was modest, no CRs, but 58% of patients had blast reduction when combined with azacitidine, and that's how most of the trials are being done now. A CR rate of 44% was seen. MRD negativity was seen in 37%, and now doublet and triplet combinations are being tested. And a triplet combination was just presented at ASH, showing a CR/CRI rate of 63%. The major drawback is anemia for magrolimab, caused by destruction of red cells that have CD47 on them. And several other agents, however, have been developed, including the trillium products that do not have red cell destruction activity and potentially making them more desirable in the post-transplant setting. So the 621 and 622 molecules are IgG1, IgG4 fusion molecules that bind to SIRPA and the FC region on immunoglobulin. It blocks the do not eat signal. In early clinical trials, they saw only transient thrombocytopenia and only 20%. The counts recover pretty quickly. No significant change in hemoglobin. They are doing some phase 1 testing in AML. Results are still pending. However, they have had some efficacy in solid tumors already. In addition to the phagocytic activity, there is NK cell activation, which has been demonstrated, which certainly is also potentially anti-neoplastic. And there's preliminary interest in performing a phase 1 study by Pfizer in the post-allo transplant setting for high-risk patients, with the potential ultimately to lead to a tier 4 myelomatch study. So if there are people that are interested, please let me know. We haven't fully engaged Pfizer yet, but this was again something that they were interested in exploring. We do need to be cognizant of the fact that this could cause, like PD-1 drugs, exacerbation of graft versus host disease. So a very careful phase 1 study would need to be done. Any questions, comments? We're only 15 minutes late. Next time we're going to have the full 2 hours. I've already asked. It's hard to get all this stuff in, and it kind of inhibits discussion. So we'll have a little bit more time to flush out some of these. Okay, thank you all.